Great. And so we've reconvened.
Hold on, Greg. Hold on. Sorry, I've got to do two separate things. Okay, we're ready to roll now.
Okay, great. So we're back on YouTube and we're recording the meeting. And we're back as the subcommittee of the Appropriations Committee responsible for higher education. And next we have, as an agency, the University of Connecticut. I think we've got the next hour and a half dedicated to Uconn and Uconn Health, beginning with Uconn Stores, and of course with the university's president, Tom Katsilas. Tom, perhaps you'd like to make some brief opening remarks. Don't feel obligated to read your testimony, but you might also want to introduce your team as well.
Absolutely. Thank you, Representative Haddad. Distinguished members of the Appropriations Committee, I am Tom Katsilas. This is my second appearance before you as the president of the University of Connecticut, and I'm humbled to be here and grateful for the opportunity to meet with you, albeit virtually. Joining me today are Scott Jordan, Executive Vice President for Administration and Chief Financial Officer, Carl Lejwe, Provost and Executive Vice President for Academic Affairs, Nathan First, Vice President for Enrollment Planning and Management. And from Uconn Health, we have Dr. Andy Aguinobi, CEO and Executive Vice President for Health Affairs, and Jeff Gagan, Chief Financial Officer for Uconn Health. So that's the team. We welcome your questions, but if you would like me while we're waiting for Senator Austin and Representative Walker, if you want to give me 30 seconds, I'll give you the high level picture.
Yeah, we're not going to wait for them to arrive before we start going through this presentation, and so you should feel free to use what time you need to sort of orient us, and then we will move to questions as soon as we're able. Well, and then we'll deal with Uconn Stores, and then after a chance to ask some questions, we'll move on to the Uconn Health Center, I think.
Yeah. Just at a very high level, it's obviously been a most extraordinary year. Like most universities across the country, Uconn and Uconn Health faced the largest revenue shortfalls in the history of the university and the institutions by a long way. But remarkably, we have fared well, both in terms of health and in terms of budget. Uconn Health pivoted its entire capacity to treating COVID patients and saving lives. It was there for the state when the state needed it. And fortunately, the state has been there for us when we need it. And I can just at a high level say how much we appreciate the support we've received from the state, most of it through the federal government, via the state. But we've faced these very high shortfalls, revenue shortfalls at Uconn Stores, 76 million this year. And we're so grateful that through the CARES Act and the stimulus funds and our own very aggressive mitigation efforts, it looks like we'll be able to close this year in the black, but we wouldn't have been able to do that without really heroic efforts on the part of our faculty and staff and students and the support from the state.
Thank you for that. I wonder if, let me ask a couple of baseline questions, and if there are materials that you want to reference from your testimony, feel free to do that. We had a robust conversation earlier with the state university system and the community colleges about their lost revenue, and also the federal CARES money and the December package in terms of money that was provided to help make the university whole. I want to ask you to sort of go through to some extent the detail about what your lost revenues look like and what the impact has been of the negative impact has been in COVID. And then also if you could talk about monies that you've received from the federal government or the state that helps mitigate those losses, give us some detail about whether or not that mitigates all of your losses. And if there's a delta, if there's a difference, how have you successfully mitigated any additional loss of revenue that wasn't covered by the federal government?
Yeah, thank you, Representative Haddad. I'd be pleased to, and I'll give the high level picture, and then I'll turn it over to CFO Scott Jordan to correct any errors I make or give any detail that the committee would like to have. But going back to last spring, FY20, we sent students home in March, and they never came back, and that represented a loss of housing and dining revenue unrecovered about $30 million. And we did receive 11 million towards that from the original CARE Act. And so that's the first answer to your questions. We received 11 million directly in FY20 from federal funds. We also received another 11 million in FY20 as a direct pass-through. So that went directly to financial aid to students. Okay. Then in FY21, because we were only able to be about 35% of our residential population to de-densify in the presence of the virus, we ended up with about a $76 million revenue loss. And in addition, additional COVID-related expenses of 14 million, something like that. So that's about $90 million deficit we were facing. In terms of what we got back from the federal government and the state through the federal government was 56 million total, not counting the pass-through. We also, from the stimulus funds, we also received another $11 million that is a direct pass-through going directly back to students. But 56 million, and I can break it down for you if you'd like on what that 56 million came in 2 or 3 different tranches, but it's against a $90 million shortfall. So it does not by itself close the gap, but we also implemented about $48 million in mitigation measures that were pretty aggressive and heroic, I would say. We had furloughs. We did a small number of layoffs. We had hiring freezes, spending freezes. We closed 4 athletic programs and 5 academic programs. These were pretty drastic actions that we took to protect the long-term strength of the university fiscally and ensure that we would be whole. We'd be in a position to come back when COVID was over. And I don't know if you'd like, I can break down the 56 million into 2 or 3 buckets, or I can turn it over to Scott to see if there's any additions or corrections he'd like to make. Would you like a breakdown?
I think we would like a breakdown. If you could provide that to us in time for the working session, that's fine. I mean, if Scott has it off the top of the head and wants to share, but we'd like. It might be in your materials already. You can just reference him.
It is page 55 of the 97-page tome that we sent you. So 55, and our team can also give you that separately, but it's a single page. It says federal COVID-19 funding.
All right, and so you just made reference to the fact that you were able to mitigate an additional, I think you said $48 million.
Right.
And are those mitigation efforts outlined in your testimony as well? How were you able to accomplish that level of?
No, they aren't. I'll give you what we did. We did. Senior managers took 13 furlough days. Other managers took 7 furlough days. We eliminated 5 academic programs, 4 NCAA sports, the hiring freeze, the spending freeze. We suspended extension services to adult learners. We suspended clinical outreach programs in dentistry. We halted planned expansion of the master's in social work that would have met the growing needs for social workers in the state. So we had to put a pause on a number of things that are extremely valuable, and it was extremely painful for us in the state to do that, but we did it in the interest of preserving the long-term strength. So these are short-term things that could come back if our block grant comes back to its full level, we would expect to be able to initiate a number of these things. These are just a few examples. As I said previously I think this committee earlier, there are no $48 million or even $10 million knobs that we have to turn. So it's 1,000 small cuts to get to 48 million. And those are just some representative examples.
And I'm sorry, did you say that that list or those 1,000 cuts are in your, are they summarized in your testimony at all, or?
I don't believe it's in one of the 97 pages, but if one of the team is here can correct me if I'm wrong, but I'd be happy to send you the page that I have. I have a slide called FY21 Budget Tracker Mitigation. I can send that to you.
That's page 78 of the 97.
Oh, look at that.
In the packet. And if there's more detail, that slide does not list the 1,000 cuts. It's the top 10, but we can get you more if we need to.
Top 10 cuts. My last question, I guess, and then I'm going to open it up to other members who might have questions, is can you paint a picture for me about what you think next year is going to look like? How much of the mitigation efforts that you've taken will translate into next year, provide savings into next year's budget? And what do you, even maybe more challenging to try to anticipate, what do you think the fall looks like in terms of enrollment, housing, food, other stuff, the impacts that you've had to endure? How much of those will continue into next year?
Yeah. We've ended, for example, the furloughs. We've begun to rehire some of the critical short-term roles. So when we project into next year, our biggest revenue risk is housing and dining, and we're modeling right now about a 90% occupancy, which is pretty aggressive because we're at now 35%. So we're assuming that we can get everyone back in and back to almost full density. We also expect there to be some inertia in terms of the response curve of the student demand. And so that represents about a $30 million shortfall that we're looking at for next year in terms of revenue loss.
90% occupancy would translate to, I'm sorry, you said a $30 million revenue loss?
That's right.
You typically, historically, you've reached 100% occupancy, although I think recently that even just prior to the pandemic, you had sort of fallen off that pace a little bit. Is the revenue loss between 90% and what you would anticipate occurring if the pandemic was around, or is it the difference between 90% and 100%?
No, it's the difference between 90% and 100%. And I think most of that we think is a kind of hysteresis effect of, we saw that people were the demand was slow to decrease. When we sent students home, we had more demand for people to come back than we actually had spaces. And then over time, once we opened up a little bit more, there was a lethargy in the demand coming back. People got used to being at home. So this is our best guess as to what we think we can populate the dorms at in the fall.
I'm going to stop for a moment. I've got more questions, but I want to allow other members of the committee to ask questions. You feel free to raise your hands and electronically, and I'll call on you in order. First up is Representative Nolan.
Thank you, sir. Good afternoon, everyone. It is afternoon, right? Yeah.
Yes.
I'm just curious to find out a little bit more about the 35% in regards to occupancy. That was.
Yeah.
Now, as far as the CARES Act money that was received by the institution, now what kind of impact did that have towards that?
Yeah, so the the first year, FY20, we received $11 million in CARES Act funding for the institution. We also received another 11 million that was a pass-through, so it did not mitigate our losses. We gave it directly to students, and it was in addition to our existing obligations to students for financial aid and so on. So it didn't replace any of our expenses. So that was against a $30 million loss in that first year of COVID, because we sent students home in March, partway through the semester. So we were 100% until March, and then we were 0% after that. So it's $30 million loss, $11 million from CARES Act. And the next year, this current year, we were at that 35% occupancy, about 4,000 students when we normally have 12,000 in the housing, and that represented the bulk of our $76 million revenue loss for housing and dining, 76 million. And against that, we received 42 million in total. So that was 21 million from the stimulus fund, right? That was in December and during the Trump administration. We also received an additional 21 million from the governor as discretionary CARES Act funding that he had available to him. So that totals 42. There's an additional 14 that we received that was for direct COVID expenses, like additional testing and things like that. So that doesn't offset the 76. That just goes that just kind of wipes out one-to-one the additional expenses. So the losses were 76, and the relief from federal and state was 42.
76 and 42.
Yep.
And the as far as the impact on the professors or the instructors in regards to being home, how many were affected, meaning that were not doing anything versus those that were?
Well, all of our faculty kept their usual workloads, and
Okay.
what we were able to do, and we're one of the few universities in the country actually to do this, was give a choice to faculty in what modality they would like to teach. So we redesigned our facilities and our classrooms to be low density, 6-foot spacing minimum with masking, and some faculty elected to come back and teach in person, and other faculty elected to teach remotely. And so it turned out, by coincidence or serendipity, if you will, we had roughly a match between the number of faculty who volunteered to teach in person and our capacity to offer in-person instruction. Because the classrooms are de-densified, we could only do about a quarter to a third of our normal instruction in person. Even if we wanted to do more, we couldn't, because we didn't have the classroom capacity to do it. But it roughly matched. So it was good for us pedagogically. It was also good for us morale-wise to be able to support our students and our faculty and staffs to the greatest extent possible, to give them choice and keep them safe, but give them choice in how they wanted to do their work during this last year.
Okay, and just to make sure I get the numbers right, can you send the list of items that you just read off that the CARES Act and the stimulus went to?
Yep, sure will. And it is in your packet as page 55 of 97 of that long packet we sent you. And but our team will send it to you separately, so you don't have to dig through that. It's a one-pager.
Well, actually, I just didn't get that high in reading it yet.
Yeah.
So if it's in there, I'll go right directly to that page then. So you don't have to send it. I appreciate it.
Neither did I, Representative.
Thank you, Rep. Haddad. Appreciate it.
Thank you. Nobody else has raised their hand yet that I can see. So I guess I get to continue asking good questions.
Sure.
I'm excited to do, unless somebody wants to raise their hand. I wanted to ask you about, what's unusual to me about the governor's recommended budget, and I'm not going to ask you to defend it, but maybe you can explain the rationale for it. Is unlike the other constituent units in higher education, he reduced the block grant to the university by $5 million and referenced the federal mitigation efforts as a reason why that's possible. Could you talk about what your perspective is on this, and whether or not you feel like the because it sounds like the mitigation efforts that come from the federal government dwarf the revenue losses, and yet because you were successful in implementing other mitigation efforts, some of which are one-time cost savings, your block grant is going to go down. And also, if there's a multiplier effect with the reduction in the block grant, could you talk a little bit about that?
Yes, thank you for the question. We did take really heroic efforts, I think, to reduce our one-time costs. And I think we probably, well, not probably, we certainly did things that no other agency in the state did. Things like furloughs. We were very aggressive to protect the long-term health of the institution, to ensure that we could recover and be there for the institution. The truth is, though, with the reduction in the block grant, we can do one time because of those efforts, but we will be delayed in restoring some of those essential services that are important to us and important to our students and important to the state. Without restoring the block grant to its full level, it's going to be difficult to restart things like the adult education programs. It's going to be difficult to restart the clinical outreach programs in dentistry that benefit the underserved in the surrounding community, but also benefit the educational experience of our dental students. It will be difficult to restart the planned expansion of the master's in social work. I don't think we can do those things if our block grant is not restored. The effect of the block grant is basically a $5 million cut relative to last year. It's what we consider, and it includes, in addition to the $5 million last year, there was a slight haircut of about $2 million. So it represents about a $7 million cut with respect to what we consider to be sea level or flat. And as you sort of hinted at, there's a hidden cost with that, which is that for the $7 million in direct support, we also lose $7 million of fringe related support. So the total impact on the budget is about $14 million.
Thank you. I'm going to switch gears on you a little bit and just talk about something that I know that you did reference in your testimony, but I wanted to get a little bit more information on. We have had extensive conversations in this committee over the years about the impact that legacy fringe costs have on the universities, first on students and through tuitions and fees, but also through your ability to secure research grants, which at Uconn is a sizable amount of research grants to support the ongoing operations of the university. You took the I think a short-term tact of subsidizing, if you want to call it that, the research grants portion by really sort of reducing the amount of money that you try to secure from your funders for research to support that fringe rate. And I think I can't remember what the funding source was for that, other revenue sources at the university, which weren't state appropriated funds, but probably included student generated dollars. Could you tell me about what the impact has been on your ability, sort of as if we want to call this a pilot, for securing research with a more competitive fringe calculation, and how long can you sustain the your ability to subsidize those research grants before you have to start going back to the charging our funders for the full value of the fringe rate.
Yeah, I think it was one of my top priorities coming in was to really supercharge our research effort and to double research and scholarship over a 7 to 10 year period. We saw a major barrier to that being the unfunded legacy costs. And I looked at the data and I could see documentation over a period of 2 to 3 years of faculty who had left and gone to peer institutions, not peer aspirants, but peer institutions, taking with them, in many cases, more than $1 million in research funding. That loss, coupled with the evidence we had that some of our faculty were not winning grants because their grants were too expensive, and reviewers explicitly saying, this grant's too expensive for what's proposed, and I recommend against it. And so we felt that we had no choice but to mitigate that disadvantage for our faculty in order to retain our top faculty, as well as to give them a level playing field on which to compete. So we took one-time funds, essentially, to solve this problem, both at Uconn Health and on Uconn Store side. And we saw an immediate impact. We were behind in new awards for the first 6 months of last year. And then at the turn of the year, a calendar year, we implemented this new policy. We saw a flurry of new proposals submitted, and we ended up closing the year with an increase in new awards from 264 the year before, 264 million to 286 million by the end of last year. So the highest total we've ever seen in research awards at the university. So I do think it was a good decision. The issue is, how do we keep paying for it? Our ability to continue to use one-time funds to mitigate the ongoing legacy costs is dwindling, and that's the essence of the problem. Is we are really appealing to you for a long-term solution to legacy costs, which disproportionately hit higher education and perhaps the airports, whereas other agencies receive the tax for legacy costs, but they also receive the revenue from the state to pay that tax. Higher education does not, and then it represents, a burden on researchers, and it represents a burden on parents and students.
Just as a follow-up point to that, I just want to stress the fact that the fringe cost that we're talking about is a combination of two portions, right? One is the real cost, which is the amount necessary for us to pay into the pension system to keep whole the pension system for your current employees. And that's calculated as a percentage of their salary. And when for a non-block granted employee at the university, the university is required to pay that, and I actually think that that's probably a fair assessment. In all of our conversations, you've never indicated that you don't think that that is a fair assessment. It's the portion that goes to pay off legacy costs, and the legacy costs are the unfunded pension liability, which in many instances is not associated with the employee that we're assessing the fringe rate to. It's just that it's a calculation, a percentage of salary that we use to allocate money and the cost for non-block granted employees. And it's that cost that I think is what has made the research grants that go in from a staff at the University of Connecticut uncompetitive. It's encouraging to hear that the market of securing research grants is as responsive to the lower fringe rate as it appears to have been. I suspect that you have done some work in determining what the economic value of bringing in extra research dollars into the state of Connecticut, expending them here, would be. I imagine that there's a an economic benefit that you've calculated. Could you share that with us?
The uptick is $24 million in new research funding, $22 million in new research funding, and that does get spent here. You can use a typical multiplier as 2.5 in terms of economic impact for the state. So it's sort of adding to the state economy something over $50 million a year. But of course, none of that comes back to the university because it's going directly to, to the investigators to do the research. There is some indirects to cover the administrative expenses and things associated with the grant, but the benefit does accrue to the state, let's say, at a higher rate than it accrues back to the university.
Yeah.
I don't know,
I'll
Scott.
keep going. If no other members have any questions, I'll keep going. So we have Uconn and Uconn Health for an hour and a half, and I will occupy their entire time. I promise you.
I think it's actually maybe time to switch to Uconn Health based on my watch, but I'm not.
I actually think that we had budgeted a full hour for Uconn, and I don't intend to sort of use the full hour. I think it does make sense because I know that there's particular concerns at Uconn Health. If you'd like to move and ask Dr. Aguinobi or someone else to sort of offer us a preview of what we're about to discuss with Uconn Health, the research grant issue, I think, is one that affects both Uconn Stores and Uconn Health.
Yeah.
But I know that there are a number of concerns about the budget of the health center as well, and was surprised to see an hour devoted to stores and only a half hour devoted to Uconn Health anyways. So why don't we move, and we'll see if other members join us after the 1:30 time period. We can go back and ask questions more broadly about any Uconn expenditures. But why don't we move on to Uconn Health?
Thank you, Representative Haddad, and thank you to everyone. I'd like to thank everyone for their leadership and dedication and support during these difficult times. So I'm Dr. Andy Aguinobi, the Chief Executive Officer and Executive Vice President of Health Affairs for Uconn Health. And joining me today is our Chief Financial Officer, Jeff Gagan. We also have Andrea Kilty, who's our Chief of Staff. I also asked a few people who are sort of in leaders who lead the operations out there. So we have Ann Harbatuk, who's our Vice President of Ambulatory Services. I have Kim Metcalf, who is our Associate Vice President of Pharmacy and Ancillary Services. And I also have, in case there's any questions about, the COVID-19 and the vaccine, not the vaccines, COVID-19 and the illness, et cetera, that it causes. We also have David Bannock, our Associate Professor and Hospital Epidemiologist. So again, like the president, I'd like to thank the leadership, all the legislators and this committee for their help and support through the years. It's really been phenomenal. I think our story in just in a nutshell, and I'm not going to read the testimony, is just to say that like as the president was saying, COVID-19 has been sort of an unprecedented time, but in many ways it has allowed Uconn Health to shine. I mean, as all of you know, there's never been, every year and every day, the medical school and the dental school demonstrates its full value to Connecticut citizens through training professionals for tomorrow and the future. So that's, and the economic development that brings to the state. But I think what COVID-19 did is it allowed also the clinical enterprise to demonstrate its value to the state of Connecticut. Everything from the COVID-19 testing to the vaccinations to the care for the people of Connecticut. So I think it was a wonderful thing for the state to have a public institution right there and ready to complement the activities of others in the state. So I'm just so proud of everyone here. It's just been a phenomenal effort. And we're coming to the tail end right now of our second surge. And many of the people that are on this call, many of the leaders here, and certainly all of our frontline workers have just done an amazing job, and it made us all so proud. When we get to the issue of finances, it's a really pretty simple story as well, where we actually, because we have been growing our revenues and growing our and keeping our expenses in line and becoming financially stronger every single year over the last 6 to 7 years, just before COVID-19 hit in February, we were actually doing extremely well. Again, if you take into account the block grant, which is a great support for us as a public institution. In addition, the governor had very graciously given not the full amount of the unfunded legacy cost for fiscal year 20, which is close to 50 million, but had given, allowed for, and the legislature had allowed for 33 million of that amount to come to us. And with our revenue growth and our increase in clinical, increase in patients, by the way, our revenue growth was about 10% on average per year for the last 6 years. Because of all of that, we were doing very well, I would say, from a financial standpoint. We were $11.1 million ahead of our budget, and we were actually on track to make about $4 million more than break even. So that was going very well. And then, of course, in March, the pandemic struck. And what happened from that is we basically shut our doors in terms of regular patients, pivoted, as the president said, to taking care of COVID-19 patients. And like all other hospitals in the state, we suffered immensely. There was a point in time we were losing about $1 million a day on average at the height of the pandemic. So we closed out the year, fiscal year 20, with COVID-19 related losses of $18.9 million. So that was our deficit. And I want to highlight that that is the first time that Uconn Health has posted a deficit result at the end of the year for more than a decade. So we've been able to manage our financial challenges, unfunded legacy costs and other challenges. We've been able to manage that internally for the last 10 years, but we posted an $18.9 million deficit. Then when we come to fiscal year 21, you might say, well, okay, in 21, you wouldn't have such a bad deficit, but actually the deficit was much, much larger. And the reason is we started fiscal year 21 with closed doors. And our plan was that we're going to ramp up and get back to our prior very positive trajectory, that we were going to get back to that over time through the year. And the loss in revenues between where we're normally at and where we would have been, plus the unfunded legacy costs, we projected when we entered this year would be a very large number, about $115 million. The actual dollar amounts it's $114.9 million is what we projected that we would be in deficit by the end of fiscal year 21. But of course, our plan was to mitigate that to the extent possible. So what we did, similar to the rest of the university, is we implemented a mitigation plan. And that included deferring capital spending by about $5 million, implementing management furloughs for non-represented managers. We received federal funds. In fiscal 20, we received about 18 million in federal funds. And in 21, we received about 18.5 million. And then we implemented a financial improvement plan, which is about 47 million at this point, which basically is expense reduction and clinical revenue enhancement. And through all of those efforts, and that was about 47 million. So you add all of those together, we were able to mitigate the projected losses of 115 million by 61 million. We were able to reduce that by 61 million, which brought us down to 53.8 million, which is actually, this is an important point, is actually the unfunded legacy amount. So another way of saying that is, in fiscal year 20, we lost 18.9 million, or deficit in 18.9 million due to COVID-19. But in fiscal year 21, we were able to mitigate the COVID-19 related losses, and we were left only with the unfunded legacy cost challenge, which is something we had known about. We knew, as you know, as the Appropriations Committee, we have talked about this even last year and the year before. So, so if you add those together, 53.8, along with the 18.9, you get our 2-year sort of request, which was, if you add those together, something like 72 million. And now, fortunately, and we're very, very thankful and we can't say how thankful we are that in the governor's budget, he put in 50 million as a placeholder there, as a proposed amount, $50 million to cover the 2 years. So we have 72 million. So if you allocate, if you say, okay, we're going to take part of that 50 million and we're going to close out the 18.9 million COVID-19 losses in fiscal year 20, that leaves about 31 million to apply to the 53.8 unfunded legacy costs for fiscal year 21. So all of that to say that it leaves a shortfall of 22.6 million. So if the governor's budget proposal was approved as is, we would have a shortfall in unfunded legacy costs of 22.6 million. The only other, so that is obviously what we're asking the legislature for is sort of approval of that additional amount in addition to what the governor has stated. And the only other point I'll make, and I'll stop talking, is another issue is capital. We haven't received any capital for 3 years. Fortunately, we're not. You didn't hear us complaining strongly about it because we've been very fortunate that the state has been so gracious through Bioscience Connecticut to fund a lot of capital assets on our campus, which has been phenomenal. But obviously, every year, if you're not doing things, you're not repairing things or doing deferred maintenance, you have a problem. So we do have for fiscal year 22 and for fiscal year 23, we do have a capital ask as well around bonding, but that's separate, I know, from this committee. So I'll just stop talking and see if there are questions.
I appreciate your presentation. When you say, I'm looking at our budget sheets, am I missing something? Is the additional operating support was $40 million. Is it $40 million or $50 million?
Oh, so we're talking about you're talking about next year, fiscal year 22.
Yeah.
Was $40 million. Sorry, I was talking about, I'm a little bit stuck on fiscal year 20 and 21, but fiscal year 22 is $40 million and fiscal year 23, I don't think there's anything in fiscal year 23.
Right. Well, so we can hope, I guess, that the loss in revenue is temporary, and that by fiscal year 2023, you'll be back on the same pace that you were prior to the pandemic, which actually does help sort of begin to help us understand that this might be a short-term problem to help you fix.
Yes, in fact, I didn't mention that what we're calling our clinical ramp up has been much faster than we anticipated. And I would say on average, we're probably about 90% on average of where we were in the past, which is great. And so it's continuing. There are some areas that may not come back fully for a while, like emergency departments or sort of stuck a little bit lower than where they were. But in general, we will be back to our trajectory. We believe that. So that's correct.
Yeah. Your institution maintains reserves?
We don't, but I'm going to turn to our CFO to talk a little bit about that.
Yes, thank you, Representative. Jeff Gagan, CFO for Uconn Health. We have two slight funds. One, we have a separate malpractice trust fund reserve, and that's held aside to settle malpractice claims against the clinical operation. Those claims do not go through the Attorney General's office. We actually handle them directly at Uconn Health. And then the other one is we have slight reserves for indirect cost recoveries, or basically return on research that's allocated back to the researchers. And there's specific allocation methods, but they maintain small balances on each side. Other than that, basically, cash is very tight at Uconn Health. So we barely have enough cash to pay the current liabilities that we actually have. And to let everybody on the committee know, to help us in fiscal year 21, which we are in, we actually applied and received $45 million of basically a loan from CMS. So that bridged any of this ramp up in other activity that we were doing through the first 3 quarters of this year. Getting that cash in as a loan stabilized us, so we were not in jeopardy of ever going cash negative. But that loan starts to get repaid in September of 21 this year as we start moving forward. So we have to build that into our projections going forward.
Yes, and Representative Haddad, if I could just add, if you don't mind. So just to be clear, we don't have reserves for operations. We just have an account for malpractice, but we don't have reserves for operations. And the other thing I wanted to say is in terms of, I think you were implying this, but when we talk about this issue, the cash issue being a short-term issue from a clinical ramp-up perspective, that is accurate. But the unfunded legacy costs continue into the future, and so those are not short-term. And I think what's happened, but what has happened over the last sort of 7 to 10 years is when the unfunded legacy costs were smaller in amount. I mean, they've been increasing each year. And when they were smaller in amount, we were simply able to absorb them in our operations and pay for that every year in our operations. But as they got larger and larger, and then finally in fiscal year 20, when it hit almost a $50 million mark, we could no longer support that, just financially. And so that is going to continue into the future because, as you know, the unfunded legacy costs continue. So we're not able to cover the unfunded legacy costs into the future. And that's something that there's a lot of discussion, as you know, that ourselves with administration and the legislature are having.
Yeah, I appreciate that. I was asking about the reserves only because I was trying to figure out how it is that you were managing these losses without going into default with any of your vendors or creditors, or in fact even the money that you provide to the comptroller for unfunded legacy costs.
So yes,
I understand you're current on all those payments, but it's the CMS loan.
Yes.
That is what's allowing you to be able to cover your bills, basically.
Yes.
Mm-hmm. Okay.
Absolutely.
Right. Representative Nolan has some questions.
Yes, sir.
Hello again. Thank you. I'm just being new on the committee. I'm just trying to understand the outsourcing research. And I just saw the slide actually, and I'm wondering about if we're outsourcing at a higher cost or is it a less cost? And if so, why are we outsourcing for?
Yeah.
Could you explain that?
So I'm going to turn it over to the president to talk a little bit more about this. But you're referring to, I think what you're referring to is when the fringe rate is higher than other competing entities for research, it becomes a mechanism to do research is to quote unquote outsource it to another institution. But I'm going to turn it over either to Scott Jordan or to Tom to talk a little bit more about that.
I'm happy to start with that. Andy, you explained it very well. It's not so much outsourcing as subcontracting. And a lot of the most important research going on these days is interdisciplinary, and often that involves collaborations across institutions. So if we propose to do a research problem on a particularly complex problem, and we do it in partnership with someone at the University of Minnesota, what we've begun to find is that the researchers will put most of the expense on the Minnesota ledger because the overhead associated with doing research there, the fringe rates are less expensive in Minnesota than they are at Uconn. And what that results in is less money coming to Connecticut and more money going to Minnesota to do the same work.
And that just seems to be a concern if we're that. And what would we have to do to? I mean, obviously we would have to lower our costs, but how much would that impact us to keep here?
That's part of why we did this using one-time funds, offset the cost of the high fringe for our faculty to create. What we're trying to do is create a level playing field so that the research gets done where it's logical to do. And, you know, a lot of these things, if it's like gathering data, the people you hire to gather the data, they could be Connecticut employees or they could be Minnesota employees. And we want to make it at least level field so that, you know, that work, we hire people in Connecticut to do that work. And without doing that leveling of the field, the money was going to Minnesota to do that work. Does that make sense? And I don't know, Scott,
No, it does make sense. It just seemed weird that we were.
Well, if
not that we were outsourcing it in general, it's that we're doing collaborative research in general. We're doing a big collaborative project on antibiotic-free agriculture, for example, you know, and so raising chickens without antibiotics, which is better for the chickens, better for the humans, better for the planet. But it's so complex that we don't have all of the expertise within Uconn to do that work. So it's done collaboratively with several other institutions. And that would be an example where, and it's a $10 million a year program. It's huge. And we want the bulk of the 10 million to stay here. And we want to send some of that money to collaborators where we need it to be complementary, where they have expertise we don't have. But we don't want people, you know, we don't want to be sending more money than we need to those other institutions. We're the lead.
Yeah. Okay. And if I can ask another question, Rep. Haddad, in regards to clinical service ROI, and it talks about investment produces 19.6 times return. Could you explain that?
Yes, we did an analysis internal. We did an internal analysis which looked at the dollars that come into Uconn Health that are actually applied to operations. So when we talk about, so you've seen you see the flow chart. I'm not sure exactly what page you're on right now, but
34.
34. Okay. So if you just wait, I'll just get to that page.
Because I would be, and mainly I'm asking is just to see how much goes to like the general operations budget or how much is spent.
How it flows is, so if you look at the current state spending, about 290 million. So people talk about 300 million coming to Uconn Health, but in actual fact, 95.8 million of that is returned by Uconn Health to the state to pay for state unfunded legacy costs.
Okay.
And that what remains from that is 194 million, which is then divvied up again for the public mission. It's divvied up between the School of Medicine, which gets about 90 million. The School of Dental Medicine gets about 27.5 million. So out of that 290 million, I'm saying only, it's very welcome, but 76.9 million. So let's say 77 million is what comes to the clinical enterprise. And we use that we have mission services that we provide. You take behavioral health, for example. The scope of behavioral health that we provide for the state of Connecticut would not be provided necessarily by a private entity. When you look at the payer mix, when you look at how much Medicaid that we provide, the dental Medicaid, all the different things that we do, and I'm talking about Medicaid specialty care, not Medicaid that walks in through the emergency department or primary care. We do that too. But actual, someone needs a joint replacement and only has Medicaid. That's why, a public institution is so important, or a public mission is so important. So when you take all of the returns on that investment that we've calculated internally, it's about, again, it's an internal calculation, it's about a $19.6 million, 19.6 times return. And I don't believe that I'm not sure as I look at it, but I don't even think that includes, or maybe it does include the economic impact that we have to the state of Connecticut, which has been it's been looked at externally, and that is several $billion.
Okay. And I just didn't think a lot of people knew that much money came in from that area. It just doesn't seem like is discussed in a large manner for us to
Right.
understand.
Yes, and by the way, it does include it includes sort of our statewide economic impact of the clinical area is 1.4 billion, and we obviously have the direct impact as well. So all of that equals 19.6 times return.
Okay. Thank you, Rep. Haddad.
And I could just add, we think that if you even if you take out the economic impact, because some could say, well, you know, there could be economic impact, whoever is spending those dollars. The direct investment of 76 or so million into the clinical, we know from our internal analysis that is returned at least dollar for dollar to the state economy. So definitely funds well spent in my mind by the state.
Thank you. I appreciate that.
Thank you for your, any other questions, Representative Nolan?
No, I'll wait to see if anybody else is going to ask stuff first.
Yeah, I've got a couple more. One that I just wanted to ask about, it just looks like it's just a question of a line item, and that's the bioscience line. Bioscience, of course, is an initiative strongly supported by this legislature to invest in our bioscience industry and your capacity at the health center to drive that industry. I think that what the governor suggested here is essentially acknowledging that bioscience investment has become sort of part and parcel of what we provide to the health center. And so I think the way I read this, if it's right, he's eliminating the line item, but adding that into your overall block grant. Is that right?
So yes, I'm going to turn it over to Jeff. Do you want to talk about that, Jeff?
Yes, correct, Representative. Bioscience was a separate line during Bioscience Connecticut when actually the construction and the initiatives really were started. That line actually had a trajectory to go up and down. Starting back in fiscal year 20, it basically steadies out at about 16 million. And then from there on was just going to grow with CPI and any increases that were there. So in discussions, we said at this point in time, since there's no more increases other than normal increases, we collapsed it with the block grant just to be combined. So we only have to deal with that one line going forward.
Okay. And then one other follow-up about the extra temporary operating support for the 40 million. Is it your understanding, and it's certainly I think it's mine, that does not come with any additional fringe support?
Correct. That 40 million, for us, it's very similar when we got the 33.2 million. It's really to help support that unfunded legacy cost portion. So it's just a direct dollars flowing in, but it does not get the in-kind fringe benefit like the block grant does.
In other words, it won't be used to pay for a portion of your staff or for staff or faculty.
Correct. Nobody will be assigned to that. It's just a cash inflow to overall operating.
Right. Okay. My last question does go back to the unfunded pension liability. I noticed the position counts here, and both the Uconn stores and Uconn Health Center are even over the time periods that they give us from fiscal year 20 to 23. I think at the health center it goes up from 1698 to 1700 to reflect the additional 2 staff that will support cannabis related expenses. But would it be safe to say that what is the relative, what is your position count overall for your agency? Are the numbers that we're provided here, I don't know if you're looking at them or not, 2,413 for Uconn, 1,700 for Uconn Health Center. Are those just block granted employees, or are those is that your total position count?
No, Representative, at Uconn, that's the block grant count.
Block grant.
Same for Uconn Health.
Could you provide me with a position count for non-block granted employees?
No problem. We will get that to
Yeah,
you.
we can send you that. We're at about 4,900 at Uconn.
Mm,
And very close to that at Uconn Health.
right. That 4,900 is a total number, or is that in addition to the block granted incident?
No, that's total including the block grant amount.
I was thinking about the fringe. It's also true that the size of the state employee workforce has been diminishing over the last 10 years as well. While your employee count, I think, has probably remained pretty steady. And in fact, I think probably the position count for non-block granted employees has been growing, I would guess, compared to the block grants, since we've held you sort of steady in the block grant for a number of years, allowing for no significant growth. And it just, that probably means, certainly means, that the percentage of unfunded pension liability as an overall, amount of our overall expenditures for legacy costs, you're probably shouldering an ever greater share of those legacy costs over time as well, right?
Yes.
Yes.
Are there any other questions? I know that you had some, Senator Flexer, I see he's raising your hand. She's raising it really and not even virtually.
I couldn't figure out how to raise my hand on here. I apologize. Thank you, Mr. Chair. Good afternoon, and thank you all for your testimony. Dr. Aguinobi, I wanted to ask you a 500,000 foot question, if you don't mind. When you've been so kind to come to this committee in the past and we've had conversations about the health center, I'm always incredibly grateful for the great work that the health center does to be the only public hospital in the state of Connecticut. And I've talked a lot about how people who live very far from Farmington in my Senate district, the only place they can get health care is at Uconn Health. And a year ago, this is sort of a long-winded question too, so I apologize. But a year ago, when the pandemic first started, I felt like I got a crash course in health systems in other places. And I learned a lot about New York's health system. And I, like many people, was really taken aback with the crisis that was unfolding across New York, particularly what happened at Elmhurst General Hospital, which also happens to be the hospital where I was born. And to discover that New York had this robust public hospital system, and yet here in Connecticut, we have one public hospital. So I just wondered if you could inform us a little bit about that, how the system here in Connecticut is so different, if you don't mind, because it's something I've given a lot of thought to in the last year.
Right. Well, I'll just, a few comments I have is, first of all, thank you for your support and your questions. I think what struck me about Uconn Health and Connecticut is that not only is this, is this a public hospital, it's a phenomenal public hospital. We're talking about a public hospital that anyone, regardless of your ability to pay, would be proud and is proud to get care in. And it's one of the reasons why for our Medicaid recipients, we get people from every county and every town in every county in the state of Connecticut. So we've looked at that. And I think every town actually we get from, I see Jeff nodding, in the state of Connecticut. They come here. It's cutting edge, state of the art care for everyone in Connecticut. Regardless of what whether they're underinsured or insured. But the great thing about it is, even if you're fully insured, you're usually happy to get your care here. So I think that's, the other thing I would say is that public institutions, a lot of times they're not noticed until there's a crisis that's a public crisis or public health crisis. And I think that's why in the pandemic, it's been so great, I think, for the state to have an asset like Uconn Health. But beyond that, I'll just take any other specific questions you might have.
Well, I just wondered, why is it that Uconn Health is the only public hospital in our state? Do you have any sense of how that developed or how that came to be? Again, I don't mean to put you on the spot. It's sort of an academic question, yes. But
I don't know the answer to that, but I know that Jeff Gagan, who's been here forever, might be able to shed some light on the history.
Thank you. I don't know forever, but I've been raised, grown, and educated in Connecticut. So we'll say a long, long time. For the difference between New York and Connecticut is dramatic. So that is the aspect of just the public health as they developed it in New York is really different. I think Connecticut had the opportunity. We had so many not-for-profit separate hospitals developed in the state. We had over 30 in our small state. There was never a need at that point in time for the state to increase or add more. I think the public was being served. So when we opened up Uconn Health, that was one of the main drivers for Uconn Health. And what we try to always point out is not a hospital. Uconn Health is here to educate students, both medical and dental. It's here for research activity, especially now in bioscience and genomics as we go through. And then both of those translate into what we do with our clinical care. So our clinical care is part of all of the education, the research, and everything else we do. But for Dr. Aguinobi's point, one of the biggest things is the access to care that we provide for the vulnerable populations of the state. So not to say that, in Hartford and New Haven, there is a larger Medicaid population and they see that. But for neurosurgery, orthopedic surgery, even dermatology, as Dr. Aguinobi said, we have people that drive from Greenwich to New London, from New Haven to Hartford. They drive by very established, well hospitals, and they come to Farmington to get their care at the state hospital. So, I think it's part of, our whole aspect of why we're here, why we're the state hospital. And then somebody mentioned before what the investment brings to the state is that development. But why there's not more, I don't know if we'd ever have a true answer for that.
Okay, thank you. I appreciate that. Thanks for entertaining that conversation. And then lastly, I guess I would just ask, I know there was some detailed conversation this afternoon with regard to numbers, and Dr. Aguinobi, I think it was really interesting to hear you describing what a strong position Uconn Health was in February of 2020. Just bottom line, what's the dollar amount that would need to be coming from this committee and a budget that the General Assembly will ultimately pass to put you back in that spot?
I think that, I'll let Jeff Gagan sort of follow up and comments so I don't misstate this, but I think the one big piece of this is the unfunded legacy costs. Right. And being able to have that be addressed where we're not having to take it out of operations would be I think the biggest issue. But I'll turn it over to Jeff to see if he has anything to add there.
Yes, thank you. I want to make sure there are 2 points, and I know we talked about it earlier. I think one point is the governor's deficiency legislation that he proposed. That deficiency is really had $50 million for Uconn Health. So under that proposal for fiscal 20 and 21, we would still be short $22 million, even with that generous amount of $50 million. Again, fiscal year 20 was the COVID loss of about 19 million. And fiscal year 21 is the unfunded legacy cost, which is 53.8. Separate to that is the budget that was proposed for the next biennium. We had the 2 items. Number one, the $40 million we're applying towards the unfunded legacy cost would still leave Uconn Health short about 18.7 million. So again, it is very, it goes a long way, but we would still have a slight deficit related to that unfunded legacy cost. And then in fiscal 23, there was proposed 0. So at that point in time, the unfunded legacy is over $60 million in fiscal year 23. But there has been no support in the governor's budget for that. So we would be, a little over $60 million just for the unfunded legacy cost in 23.
Thank you. Thank you very much for that information. And thank you, Mr. Chair. And if you switch back to the university as a whole, I'll have questions then, but that's all I have for Uconn Health. Thank you.
Thank you.
Thank you. Yeah, I am looking for additional questions if the people have them. I did want to ask a non-budget related question to Dr. Bonnick, and he's been very kind to be sitting through this. I think I'd rather have answer this question and then go back to fighting infectious diseases. You know, as policy makers here, we're obviously tasked with trying to envision, you know, an adequate budget for next year. And that includes not just post-secondary education and higher education, but also in all other realms, including education, you know, primary and secondary education. A question that's been sort of percolating in my head. I have a 7-year-old. I know Senator Flexer has a newborn. Lots of other members of the General Assembly have young kids. As we're moving headlong through a vaccination schedule that says that adults will be vaccinated maybe by midsummer or so, we're still facing a situation where even in the fall, it is very likely that 25% of our population, young people and kids, will be unvaccinated. And I'm having trouble figuring out what the fall looks like in schools and in communities when adults are fully immunized or vaccinated, maybe not fully immunized, but at least vaccinated, but our children are not. And I was hoping that you could provide some insight to us as we, you know, as we wrestle with our budget and try to figure out what our spending priorities are, and deal with a lot of other policy ramifications about what accommodations we should be making in our own head for the fact that our children will be are not likely to be vaccinated until much later this year.
Go ahead, David.
Sure. So thanks for the question, Representative Haddad. I also have a 7-year-old, so I share the same exact concerns personally. So, you know, a few thoughts, and we look at what's going to happen with kids and vaccines. You know, the Pfizer group has actually finished enrolling a cohort of age 12 to 16, and that was finished in the end of January. So we'll have data from that in the next couple of months. And if everything looks good, there's a good chance that the vaccine will expand to include that age cohort. The eligibility through the emergency use authorization and FDA. So I think that is something that is potentially on the horizon when we think about teenagers. But your young children, you know, I think Pfizer is looking to start a trial with young children, but that will take more time. And I wouldn't anticipate that young kids will be vaccinated in the near future. So when we start to think about the fall, you know, I think a few things that that are going to be really critical are thinking about what's happening with the virus in the community level. If, you know, virus transmission is low, you know, think about where we were at the end of last summer. You know, I think that can go into the school year with a lot of with some reassurance. You know, we also have more data on the role of kids in spreading COVID-19, and really the data supports that even schools, that there were actually 2 studies that were just published in the CDC journal over the last month that show that even when schools are open in settings of high transmission, there's one from Wisconsin, another one from, I believe, North Carolina, the rate of transmission that occurs in schools, either between students and teachers, is low. So I think that provides some reassurance, and the CDC, you know, put out initial guidelines on how schools should reopen. Some of the mitigation factors, which include things like distancing and masking, and you know, I think that'll be part of the picture. But you know, I think you know, there's a growing appreciation that if we can vaccinate all of those around, other than the kids, the young kids, including potentially teenagers, you know, we'll have enough protection in the community to support the safe reopening of schools, even with kids, if kids aren't vaccinated, young children, I should say. You know, based on both the protection that's out there from vaccinating the rest of the population and the lower risk that kids pose in transmission in the school setting. So I think that's the goal, and what may lie ahead. Again, you know, with all the caveats that with COVID, we can only predict so much, but you know, I think that there's the potential to expand vaccination to teenagers, which will be helpful because they have been shown to be involved with transmission both between each other and in the community. And you know, thinking about school-age kids, you know, in the future. But you know, some of it we'll have to see how it unfolds.
Just one follow-up question, I guess, to that, which is, you know, not all schools in Connecticut are created equal. You know, I feel really fortunate. My daughter goes to a school where there's just 10 people in her classroom. She goes 5 days a week and there has been few problems. But there are school districts, and my brother is a teacher. He teaches in a school, in a private school district, where there are 30 kids in his classroom. Is the guidance that will be coming out in the fall for the reopening of schools going to be adequate? No matter what will the guidance say about what the appropriate size of a classroom would be in the fall? I imagine kids will still and teachers will still be wearing masks, but are there other things that we need to be thinking about and planning for moving ahead so that we can reopen schools? We know their teachers will be safe, but to prevent rampant infections among school kids in districts where kids just don't have the space to spread out as they are maybe in other school districts.
Yeah, and I think the guidance really focuses on the three primary mitigation factors: the distancing, the masking, and the ventilation. If you can maintain all of those, that's the optimal setting. So adequate distance between students, masking, and high quality ventilation. If you need to modify one of them, you can enhance another. So for instance, in a less ventilated school, a school with maybe not optimal ventilation, if you maintain even a higher level of distance, accommodation in the classroom, lower capacity, those kinds of things, you can mitigate for that. But those are the three things to focus on. It's the distancing, masking, and ventilation capacity. And I think that's where we can put our efforts into ensuring safe school reopening. And that's actually, it's pretty well laid out in the CDC guidance came out I think about 2 or 3 weeks ago. And they go through those principles in detail. And I think that guidance will still evolve. That was the initial guidance put out with the new administration and the new CDC director. But I think that's going to continue to evolve based on the science. So we'll see how it goes. And I will couple it with also all that we are learning from what other countries are doing. So for instance, there's been a big focus on 6 feet of distance as the standard here in the United States. Other countries are using different standards. Like in Europe, they use 1 meter as a safe distance between individuals and schools, and they're collecting data looking at school transmission. So I think we'll learn a lot from what's happening in other countries, as well as the actual emerging science on virus spread and transmission. So I think a lot to learn, and it'll keep evolving.
Well, thank you for being here today and for sharing your expertise. You're a great example of what a great public hospital in Connecticut has to offer the population. I appreciate your sharing those thoughts with me. I don't know if anybody has any other questions on Uconn Health Center. If not, then we can go back to Senator's question, which I think was Senator Flexer had a question about Uconn stores. Senator Flexer.
Yes, thank you, Representative. I actually, unfortunately, have a deadline in my other committee that I'm the chair of that I need to. So I apologize. I will get the question though to the university through a different means. Thank you very much.
Great. Well, thank you very much. I'm sorry I took that time. I didn't realize that you were on a deadline. Are there any other questions by members of the committee? Seeing none, I think we're all set then. I think, well, I'm going to recess this public hearing just in the event that I'm not supposed to adjourn it. But I think that concludes our activity for the day. I thank all of both President Katsouleas and Dr. Aguinobi and all of the staff from Uconn Health and Uconn Stores from being here and answering our questions. We appreciate it. Our work sessions will be next week, and I'm sure that our committee members will have additional questions and concerns. But thank you very much for your offering your expertise here today for us.
Thank you for your time, and thank you for your leadership on behalf of all the citizens of the state.
Yeah, same. Thank you to all of you.
Thank you very much. And Sue, there's our committee administrator. Can we adjourn this hearing, or are we recessing it for later?
I must confess that I wasn't wholly paying attention. Please, Dr. Andy and President Tom, don't hold that against me.
No.
I just want to make sure that if there is follow-up information to be gotten, that it comes to me and I will distribute it to the subcommittee.
Okay.
Okay. Okay. You're welcome. And yes, Representative Haddad, you may adjourn.
And so the hearing that's later isn't a continuation of this hearing, it's separately noticed, and okay, very good. Then
Yes.
here with that advice, then I will declare